Hi, Rural Health Summit participants. My name is Shannon Studden, and I'm a program specialist with the National Rural Health Resource Center. So as you may remember, the purpose of this webinar is to share some key information on national and state trends related to access to quality, affordable healthcare across the United States and the state of Minnesota. So our goal for this webinar is to keep the national and state context in mind as you explore the local level through your assigned community profile. During the first day of the summit, you'll be discussing your assigned community with small groups. And on the second day, we'll kind of zoom our focus back out to the state level. So you'll likely be able to draw from the information that will be presented today as we have discussions through both days of the summit. So I'm here with a few of our partners on this project from the College of St. Scholastica, Brandon Olson and David Mark. So I'll tell you a little bit about them. We'll go over the agenda and then I'll turn things over to them. Dr. Brandon Olson holds a PhD in information technology with a specialization in project management and is a certified project management professional. Dr. Olson is a professor and director of the Master of Science in Applied Data Analytics program at the College of St. Scholastica here in Duluth, Minnesota. Prior to his tenure at St. Scholastica, he was employed as a project manager, leading software development projects in the business services, telecommunications, hospitality, healthcare, and pharmaceutical fields. Dr. David Mark is an associate professor, the Health Informatics and Information Management Department chair, and the Health Informatics Graduate Program Director at the College of St. Scholastica. Dr. Mark has a master's degree in biological sciences and a PhD in health informatics from the University of Minnesota, and is a certified health data analyst. Dr. Mark is a frequent speaker at state and national meetings and workshops where he speaks on topics related to healthcare data analytics. He's an accomplished researcher and author on topics related to health informatics and information management workforce trends. So here's what we'll cover in our time together. If we can go to the agenda slide, Brandon, thank you. So the data presentation will start just talking about the current state methodology, go through some comparisons at the county, state, and national levels. We'll look at some trends in rural healthcare, and then we'll kind of wrap it up with a summary and talk about next steps as far as your pre-work goes for the summit. So with that, Brandon and David, I will turn it over to you.
All right, thank you, Shannon. So first, we're going to take a look at the current state, looking at some comparisons between the county and the state and the national levels. First, I want to talk about the methodology so we can see where this data came from. Several different data sources. The primary source that we used for this study was the 2020 County Health Rankings data, which summarizes a lot of different data sources. But in addition to that data source, getting data from the US Census Population Change report, the FCC Broadband Health Report, Medicare's HCAHPS and their Timely Care study. Also looked at the Homeland Infrastructure Foundation, CMS Medicare enrollment, and the CMS Medicare Spending report as well. Our data, we put this together using the R package, and then from there, move the data into Excel and Tableau to do some further analysis. And so this is that's the data that we use for the study. And when we take a look at this, first we're going to take a look at some geographical maps of the state of Minnesota to take a look at the counties that we consider rural, the different populations across the state, access to broadband, and also the median household income. So if we take a look at this map right here, what you see here in green represents all the counties in the state of Minnesota that are classified as rural. So these, by the Office of Management and Budget, we use CBSA, which is a core-based statistical area to define metro, micro, and neither. So the metro counties are indicated in this blue-gray color, and everything else is considered rural. So when we talk about rural counties in the state of Minnesota, these are the counties that represent rural Minnesota. Next, taking a look at broadband. So the FCC report looks at broadband across counties, and actually, you know what? This is population. So first we're going to take a look at population, I guess. So you can see here population density, certainly where we would expect it in the Twin Cities metro area, St. Louis County. We have Olmsted County. These are kind of higher populations, and the darker colors are the the higher populations, whereas the rural counties, such as Cass County or Lake County, you can see that those populations are fewer. So you can see the population densities in the states differ, but there's certain regions which we're not too surprised at. Now we can talk about broadband. And broadband is quite a bit more spread out than what we see with populations. So there are counties such as Beltrami, which is 97.4% of the population in that county has access to broadband. Cook County is another county that has high access to broadband. 98.90% of the people have access to high-speed internet. And we're seeing that here down in the southern Minnesota. So there's large populations or large areas of the state that have good access to broadband, but there's also some areas which broadband is a little more sparse. 37.10% of the people in Redwood County have access to broadband. Up here in Clearwater County, only 3.5% of the population has access to broadband internet. So there are some significant differences, but it's not necessarily based on the population density, where the larger population of the state exists. It's spread out more than that. And then finally, taking a look at income. And income, this is the median income for each county. And you can see in the Twin Cities metro area that is higher. And then in the rural Minnesota, it's not quite as high as it is in the Twin Cities. But you can see that there is some differences between rural Minnesota and the metro areas. All right, so now I'm going to take a look at some comparisons between the rural populations in the county and across the country. Looking at populations, income, access, risks, Medicare, enrollment, spending, quality, and timeliness measures. So first, taking a look at the rural populations. So when we talk about rural Minnesota, rural Minnesota in those counties that I showed you before, that represents 22.2% of the population in the state of Minnesota, or 0.4% of the population across the entire United States. And that's at 1.2 million people. Now, the state of Minnesota at 5.6 million people is 1.7% of the United States. And across the United States, we have about 46.1 million people there, and that represents 14% of the US population lives in classified in rural areas. So you can kind of see how, when we talk about rural Minnesota, that represents a smaller portion of the United States, but it's a pretty significant portion of the state of Minnesota. Now looking at household median incomes. So this is the average median income for each of the counties. So if we take a look at rural counties, we're seeing that the median household income is about $55,000 a year, where all of Minnesota, all counties in Minnesota, is slightly higher at $60,000. But both of which are above the median income for rural US and all of US. Now, access to healthcare is important. So we took a look at the number of providers per population for rural Minnesota, all of Minnesota, rural US, and all of US. So each of these numbers represents the number of the number of people per physician. And this is per physician, not necessarily primary care, but for a physician. So in rural Minnesota, we have 1,501 persons per each physician, whereas in all of Minnesota, it's slightly more, 1,507 for each physician. Across the United States, there's even, the disparity is even greater, where rural US has about 2,000 residents or people per physician, whereas across the United States, it's close to 2,000. And we're seeing also surprisingly, not as big as a difference for mental health access to mental health professionals. 905 people for each mental health professional in rural Minnesota. Now looking at health risks. So these are some common risks associated with health, and we can take a look at how rural Minnesota and all of Minnesota compares to rural US and all of US. So rural Minnesota and all of Minnesota very close. We're about 15% of the population are smokers, whereas rural US, it's closer to 18%, and same for across the United States. Now obesity. Obesity is going to be those people that report a body mass index that's 30 or greater is what's being classified as obese. And we can see that the numbers there are pretty close. Rural is slightly higher population of obese than all of Minnesota. But both rural and Minnesota is less than the United States. Now, poor health, these are the people that that self-report as having fair to poor health. In rural Minnesota, we're seeing that's 13%, which is slightly above all of Minnesota at 12.5%, but both of which are far below the US average at 18.5 for rural US and 17.9 for all of US. Child poverty, this is the percent of the population that are 18 and younger living in a household that has an income that's below at or below the poverty level. For rural Minnesota, we're seeing 14.6%, which is higher than all of Minnesota, but both of which again are well below the average for the United States. Now, life expectancy. There's not a big difference between rural Minnesota and all of Minnesota, slightly shorter life expectancy, but again, as we're seeing with these other measures, that we are in a better state than the rest of the United States. Here, rural US, 77.1 is the average life expectancy versus 77.5 for all of US. So enrolling in Medicare. So what we're seeing here is enrollment in Medicare has been pretty consistent between 2015 and 2018 at about 11.9% for all of the United States. We're seeing pretty steady but slightly declining enrollment in Medicare and rural Minnesota, and same for all of Minnesota. But when we look at Medicare alternatives such as Medicare Advantage or other plans that are not run by the government, we're seeing increases. So rural Minnesota has, we're seeing an increase there from 11.5 to 13.2, and same for all of Minnesota, 8.9 to 10.3. And then the shift across the United States is also increasing from 5.4 back in 2015 to 6.5 in 2018. So we're seeing increases there, and we're seeing relatively flat or maybe slightly declining for Medicare enrollments. Now, Medicare spending. So if we take a look at comparing the state of Minnesota to the United States, we're seeing some differences, not significant difference, but they are different. We're seeing actually higher inpatient costs in the state of Minnesota compared to the US average. But the remaining measures, Minnesota is below the United States in post-acute care, hospice, outpatient, equipment, Part B drug, ambulatory, or ambulance, I guess, and also the total spending. And these are total spending per participant or per enrollee. This is what the average cost is. Now, taking a look at quality measures, and these are, there's a different type of quality measures that we're going to be looking at. These are going to be based on data, and then the other sets are going to be based on patient surveys. So the first here is preventable hospital stays. And this is one scenario where Minnesota falls behind the United States. So we're seeing Minnesota had 6,015 preventable hospital stays, whereas across the United States, we're at 4,368. So this is indicating the hospital stays that could have been prevented with better routine care, and also is indicative of people that are not using primary care physicians, but more of getting their care through urgent care or emergency room care. Now, another quality measure is screening. So screening here represents the female population ages between 65 and 74 that receive annual mammogram screenings. So in the state of Minnesota, we're seeing 46% of that population is getting annually screened, whereas 43% of the US population is getting screened. And vaccinations, this is going to be those people enrolled in Medicare that are getting annual flu vaccinations. So about half of them, half the population in Medicare is getting flu vaccinations, whereas across the US, it's 46%. All right, so some other quality measures, and these are going to be based off of the HCAP survey. These are surveys by patients with their levels of satisfaction with their experience in the healthcare field, with the healthcare professionals. The doctor differences, the doctor's score represents the average score from the patient satisfaction regarding the doctor's communications. And we can see this is very high, 93, they scored a 90, an average of 93 compared to a nationwide average of 92. The next column represents the patient satisfaction with the nurse's communication. And that's at the exact same level as the doctor's communication. Now staff represents the patient satisfaction with the staff's responsiveness. And in Minnesota, we do quite well there compared to the national average. Discharge is the patient satisfaction score based on the information that they're provided at the time of discharge. And then also we have the medicines. This is going to be the patient satisfaction with communication about their medications that they've been prescribed, which is one of the lower areas for this patient satisfaction survey. Then we take a look at cleanliness. This will be the patient satisfaction with the cleanliness of the facility and also the quietness of the facility. We can see that Minnesota does, again, as we see almost across the board here, that Minnesota ranks higher for cleanliness and quietness. And then the transition represents this patient satisfaction with the quality of care during care transition. And then finally, the recommendation, the likelihood that the patient's going to recommend that facility to others. And we score rather high there as well. All right, so now the timeliness measure. So when we take a look at this, we have two measures that we're focusing in on here. First is the admit time. So this is going to be the average time in minutes that a patient spends in the emergency room after the doctor has decided to admit them, but before they're actually leave for their room. So in Minnesota, it takes about 2 hours between when the doctor decides to admit them and when they actually make it to their room. Compared to the United States average, which is 100 minutes. Now the depart time, there's a big significant difference between the two times here. The depart time represents the time that they spend in the emergency room when they are not going to, or in the emergency department, when they're not going to be admitted. So across the state of Minnesota, the average time is about 53 minutes versus 141 minutes across the United States as an average time. So we're seeing a big difference there. So that's what the different measures look like, looking at the counties across the state of Minnesota, focusing on some of the rural counties, also looking at the state averages compared to the US averages. So you can see where our strengths and where our weaknesses are at and things that we should be looking at in the future. So David, Mark.
Great, thank you, Brandon. I'm going to be sharing with you some information that to offer a little more context around, the current status of the rural healthcare in terms of trends that we're seeing in rural healthcare and ways that we could potentially disrupt those trends. So when we're talking about healthcare in rural communities and as well as urban communities, this really is relevant to healthcare across the United States. We're really talking about three major focus areas. It's access, affordability, and quality. In a perfect world, we do want everyone to have access to the same type of care across the United States. In terms of quality, we want people to have the care delivered in the same way across the country. However, we do see that that can be impacted by geographic disparities. And in terms of affordability, healthcare that all can afford to be able to get the care that is needed. When we're talking about trends in rural healthcare that could impact quality, access, and affordability, there are some that really come to the forefront, particularly when we talk about rural healthcare in Minnesota as well. What we're seeing is that the demographics continue to change in rural areas, that we are seeing that in rural areas there is actually forecasts that that show that there will be a decline in the population in rural areas overall. However, it's possible that the migration patterns in terms of immigration and migration into rural areas could revitalize the economies in some of those rural areas. This is largely due to factors that are related to the types of jobs that are available in rural areas. So we are seeing the demographics changing, but we do overall see declining population, although it is difficult to forecast some of that, so there could be variance depending on the rural community. Another trend in rural healthcare is increased healthcare costs and reimbursement. Rates of public insurance in rural areas tends to be higher as compared to that in urban areas. And this is largely due to the fact that there tends to be a higher population of people 65 years old and older in rural areas. I'm sorry. There tends to be people in rural areas that also have incomes tend to be slightly lower in lower areas. And there's lower employment, which can have an impact on the ability to access employer coverage, therefore relying more heavily on public insurance. There's also challenges in rural areas related to broadband access and connectivity that Brandon had already explained. When we're talking about broadband, this is being able to get high-speed internet in the homes, but we're also seeing that wireless cellular connectivity can be a challenge in rural areas, and that as compared to urban areas, rural areas can have much more limited access to both broadband as well as cellular signal. When we're thinking about rural trends as well, we're seeing that there's continued integration of technology into healthcare. This is oftentimes taking the form of telehealth services. So for instance, is providing access to a wide range of types of care to rural communities. Telehealth is one way that can provide better access to different types of care. This includes access to behavioral health and mental health services, for example. Rural areas, we are seeing more support for the capacity to build those telehealth services. However, the trends to leverage and use those services is still growing in those areas. With the rising cost of healthcare, there also is a trend of consolidation of resources. We're seeing more mergers happening in rural healthcare, more networks being formed to support better levels of reimbursement across rural healthcare markets. This can have an impact on the rural community in good and bad ways in some ways, that having a rural facility that can understand and provide the care and be an integrated member of the community can be a challenge with some mergers and acquisitions. However, and we are seeing that this could provide some stability for the rural market, rural healthcare facilities to be able to have the financial strength to continue to survive through challenging times. Workforce shortages are a problem in the rural communities. We are experiencing workforce shortages in rural communities, not just in the healthcare sector, but there are challenges in many different sectors. There also tends to be, and Brandon had provided some statistics on this, lower physician and dentist ratios in rural areas where there's just fewer physicians, fewer dentists, compared to the population size of what would actually be required. These are considered healthcare provider shortage areas, otherwise known as HPSAs. There's shortages in not just physician and dentists, but also in mental health care providers as well. When we talk about progression towards integrated behavioral health, this is partly to address those challenges in mental health care provider shortages, where behavioral health services are now being integrated into primary care, where we do see either physicians being providing that level of care, or we're seeing more support around social services with social workers and providing behavioral health care that would be appropriate for that population. When we think about other aspects of care that need to be understood, we see that the social determinants of health are something that should be emphasized and understood in the rural market. This is where social and economic factors can impact the health of the population by introducing challenges around access, affordability, and quality of care in certain areas. So this is where understanding education levels, median household income, and other factors that can be related to that as it relates to the health care that is being provided to that population. When we think about ways of that communities are attempting to disrupt some of these trends, what we're seeing is that healthcare, rural communities are, the consumers themselves are driving change, causing disruption in these trends. So as it relates to affordability, healthcare consumers are becoming more focused on the cost and convenience of care, seeking out telehealth options, for instance, or mobile health options for getting care immediately, quickly, as well, and in an affordable way. We're seeing growth in terms of the use of those services in rural markets, and that's really impacting the access and affordability of those individuals and that care being provided. Changes in the healthcare delivery and payment models is impacting quality and affordability of care. This is where we're moving from fee-based reimbursement methods to value-based payment methods that can greatly impact the rural marketplace, focusing on the quality of care that's being provided and being metrics. Actually, these healthcare rural hospitals actually being evaluated based off of their quality of care rather than the volume of care. Technologies are supplanting traditional care services with the widespread adoption of the electronic health record, as well as promoting greater access to care through telehealth services. This is creating disruption. There are significant financial pressures that are impacting the decision-making of healthcare facilities. We discussed that mergers and acquisitions are happening. This is largely due to financial pressures within those organizations. There's also the payment methods, looking at the formation of accountable care organizations to take part in those value-based models. These are all ways and disruption that is impacting the affordability as well as access to the care, and also tying that to the quality of care. There are changing roles that are changing the way that healthcare is being provided. And when we talk about changing roles, is the local economy of rural economies and the workforce more broadly than just the healthcare workforce. This can impact the communities that these rural healthcare facilities are located in, creating pressures around the employment options for individuals. We are seeing that there are widespread healthcare shortages in rural areas, and ways of disrupting that is providing cross-training methods where there's expanded roles of healthcare professionals trying to meet the demands of the workforce by creating creating options for people in the healthcare facilities to be cross-trained in being able to provide different levels and types of care. Healthcare organizations are complex. They need to be adaptive, and this is where adopting leadership skills and strategies and methods of managing an organization can greatly disrupt the decisions that are being made by an organization that could impact the local community as well as the healthcare organization. So it's another example of a disruptor. And then lastly, our global integration and interdependence. This is related to climate change, where our climate change can have an impact on the access to food, the employment in the area as it relates to farming, for instance. It can create more challenges around those utilizing water resources and create a more costly situation. So climate change can greatly impact a local community. Pandemics, the COVID-19 pandemic, and that outbreak has created a real disruption in the in terms of the healthcare setting and our preparation for these pandemics, our response to them, and just the strength of the community in terms of educating the healthcare consumers around the risks and appropriate use of healthcare services. That was an unexpected disruptor that we've seen significant challenges as a result of that. So what happens if we don't disrupt some of these trends in rural healthcare? What the major, what are the kind of the end game in terms of the rural healthcare space is if we don't disrupt the trends in rural healthcare, we could see fewer rural healthcare facilities and providers, thereby creating more problems around the access to care. It might require individuals to have to travel further from their home to get the type of care that is needed for them. So this could also create challenges in getting timely care. We may be unable to treat a wide range of health issues. Care may be postponed or not available, thereby impacting the quality of care in these areas. And communities may not be able to afford the care that is needed if we don't disrupt some of these trends, thereby impacting affordability. So this is a time in which we have to understand the trends in the rural healthcare space, implement policy within these communities and create legislation even to be able to have infrastructure in an environment where care in rural areas can be accessible, affordable, and of high quality. So when we're talking about ways in which we can respond to these trends and understand the disruption and providing recommendations for policy change, one thing we can try to do is model the future of the rural healthcare space. So in order to do this effectively, we need to construct a model. And how that construction can take place is to understand our history, the past, and the trends in the past that have occurred to predict what will happen in the future. This is where we need to understand the factors that can impact access, quality, and affordability, as well as identifying measures of access, quality, and affordability. So what are ways in which we can measure access? What are ways in which we can measure quality as well as affordability? So when we think about the factors that can impact access, quality, and affordability, we not only have to think about all the factors that can impact those components, but also which of those factors are most important with regards to access, quality, and affordability. When we think about measuring the access, quality, and affordability, which measures are most reliable and illustrative of those three components? Those are two requirements that we need clarity on in order to construct a good model to predict what will happen in the future and the disruption that needs to take place now for us to have an impact on the rural healthcare space so that care can be accessible, of high quality, and affordable. So the ultimate goal of building a model is to use current trends to predict future trends based on disruption and to develop recommendations for disruption to maintain and improve access, quality, and affordability. And this is where we need your help, is to really understand what are the factors that can impact access, quality, and affordability. They can include measures such as broadband connectivity, for instance, median household income, and then what are the measures of access, quality, and affordability? Is it the amount of money that people are spending on healthcare? Is it the rate of mental health in rural communities? Are those ways in which we can measure quality and affordability? What are the most reliable and illustrative methods? There needs to be further discussion on identifying those and prioritizing the factors that it can impact them. So this is where we need your help and clarity in those two tasks: identifying the factors and identifying the measures. So with that, I'm going to hand it over to Shannon, who will explain some of the next steps and how we're going to respond to the environmental scan.
Thanks, David. And thanks to Brandon, to both of you for sharing your data and sharing your expertise with us. And I would also just like to thank Summit participants for taking the time to go through this information with us. We hope that the information that Brendan and David presented helped paint a picture of the current state of healthcare access, affordability, and quality at the national and the state levels, so that you have kind of a good launching point for gaining insights into your assigned community profile as you read through that document. And that David's discussion of the elements for a model for the future of rural healthcare kind of give you an idea of where we're going with this summit. So we're really going to be asking for your input as far as the most critical aspects of these elements for looking at the future of rural healthcare. So with that being said, between now and the start of our virtual summit on June 24th, we ask you to dive into your community profile, read through the Trends and Disruptors Literature Review document that David really set up nicely today, kind of going through an overview of the trends and disruptors. There's a lot more detail in that document. And we've also provided a reflection worksheet as a kind of a tool for you just to process a lot of the information that we're throwing at you. So we'll ask you just to jot down your responses to the questions on that reflection worksheet as you work through these two documents, the community profile and the trends and disruptors document. So thanks again for being willing to dedicate your time, David and Brandon, and all of you summit participants. And we know it takes a lot of time and energy to get ready for this and to contribute to the summit. But please contact me or any of us here at the National Rural Health Resource Center anytime if you have questions about the summit or would like more information about any of the topics that were presented today. So thanks again, and we look forward very much to seeing you on June 24th.